Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith-Rogers. Today, in this two-part episode, Accessing Mental Health Care in ICE Custody, Dr. Solomiya Tsymbalyuk is a fourth-year psychiatry resident at the University of Maryland, where she and her team were asked to provide psychiatric care to a man in ICE custody. In part two of today's episode, Dr. Josh Sharfstein then talks to Dr. Katherine Peeler, a medical advisor for Physicians for Human Rights. Dr. Peeler offers an inside look at how healthcare is provided in ICE detention centers and discusses the barriers to mental health care for many in custody. Let's listen.
Dr. Solomiya Tsymbalyuk, thank you so much for joining me today in Public Health on Call.
Happy to be here.
I'd like to ask you to introduce yourself to our audience.
Of course. I'm a fourth-year psychiatry resident at the University of Maryland and Shepherd Pratt residency program.
And if I recall, there are only 4 years in a psychiatry residency program, so you must be well on your way to becoming a full-fledged psychiatrist.
I'm very close.
Well, it was in the process of your residency that you became aware of a case that has lingered with you, so much that you wrote about it in a medical journal. I'd like to ask you first to set the scene.
Sure. So this happened in a large emergency department in a major U.S. city. We were being asked to evaluate a patient who presented in the custody of ICE.
And by ICE, you mean Immigration and Customs Enforcement.
That's correct.
And was it in the morning, the middle of the day? What time?
This was the evening, not quite night, but late afternoon to evening.
Okay. And the person comes in. Could you describe what that was like?
Mm-hmm. This was a middle-aged man who was restrained at both his hands and feet. He was accompanied by 2 ICE officers.
And what was ICE asking for in bringing this person to the emergency department?
There were 2 parts of this. The first part was that they were asking for him to be cleared by psychiatry for transport, and the second part was that his medications be administered to him.
So let's take those in reverse order. He was on medicines?
That's right. So this is a patient who had a history of schizophrenia, had been prescribed medications for the treatment of schizophrenia, and the ICE officers who accompanied him also brought multiple prescription bottles for the patient for the treatment of schizophrenia.
And they were asking you to give the patient the medicines. Why couldn't they do that, or why couldn't the patient just take the medicine?
Yeah, and that was our question as well. We don't usually get patients who bring their medication with them, but also ask the hospital to administer it. And in this case, the ICE officers explained that while there is a nursing staff member at the ICE facility where the patient was being held, that person is only there during business hours, which means that given that it was evening, no one at the facility could administer the patient's medications to him.
And as far as you know, did the team give the patient the medicine that he needed?
We did. We gave him his prescribed medications.
And then the first part you said was clear him for transport. Can you explain what that phrase means?
Mm-hmm. So in psychiatry, clearance means a comprehensive psychiatric evaluation of the patient. And what the ICE officers were hoping that we would do would be to write that the patient was not at an elevated risk of suicide or harm to others.
And how did that evaluation go?
As a result of our evaluation, we found that the patient was not actually cleared. In fact, what we documented was that the patient was at an elevated risk of suicide and would require a higher level of observation, suicide precautions, and regular mental health treatment.
Tell me more about the suicide precautions that you were recommending.
So suicide precautions can mean a variety of things based on the facility at which they're being instituted. But in general, it means removing any potentially harmful objects from the space that the patient is in and observing them closely, meaning one-to-one observation.
Did you get a sense that that was going to be possible, that level of care wherever the patient was going?
Unfortunately, when we delivered these recommendations to the ICE officers, they responded that they were not able to ensure that they could meet these standards, but that they would pass these recommendations on.
So you have a patient that comes in shackled, at risk for suicide, and the team evaluating the patient is obviously worried about this, gives recommendations, but you don't have a clear sense of whether they will be followed.
Unfortunately, that's where we were.
And is that in part why this case has lingered?
Exactly. I think it opened up many questions that we still don't necessarily have answers to.
So tell me one of those questions.
I think one of the primary questions is going forward, how can we navigate interactions in which we psychiatrists are being asked to evaluate someone in ICE custody?
I imagine that you evaluate people who are in the custody of other types of law enforcement, like police or sheriff's departments for people who are in jail and prison.
That's right. We actually see those types of patients not infrequently.
And what is that like?
So, in the case of patients who are in police custody under arrest or in the custody of the Department of Corrections, we similarly do a thorough psychiatric evaluation. And at the end, we're able to synthesize our recommendations. And we have some assurance that those recommendations will be passed on to the receiving facility, whether it's a jail or a prison.
In that case, if somebody is suicidal, you wouldn't necessarily admit them to your own hospital.
That's right. We would document that we have a concern that this patient is at an elevated risk of suicide and that they require, as I was saying earlier, close observation, one-to-one suicide precautions, and regular mental health treatment.
So why wouldn't that apply the same way to ICE?
I think there is a clear legal standard for the healthcare of incarcerated individuals. But in the case of ICE facilities, I'm not sure what that standard is. I do know that there are some standards in place for mental health treatment and, regular health treatment for individuals who are in ICE facilities. But based off of the interactions that we had with this particular individual, it wasn't actually clear whether there was any type of prescriber at the facility. It wasn't clear that there were 24/7 nurses available to administer medications. And in general, we just did not have a sense of what kind of treatment was available.
What kind of guidance do you think would be helpful for health professionals who are on the front lines like you in taking care of individuals brought by ICE?
I think that guidance from both professional societies and legal societies about how to navigate these encounters would be useful because individual clinicians practically are not sure what to do in these situations, whether we can admit patients to inpatient psychiatry or not. And then ethically, we have this duty to treat patients to the best of our ability, but it's difficult to fulfill that if we're not sure what type of facilities we're returning these unsafe patients to.
Looking back at this case, what are you worried about?
I guess my biggest worry is that we evaluate someone who has an increased risk of suicide and we return them to a facility that doesn't have adequate monitoring, that doesn't have adequate mental health treatment. And the bad outcome is that this patient does, in fact, harm themselves or someone else. And that would have been preventable had we offered a higher level of psychiatric care.
Sounds like you'd like to see this issue be a concern of more than just psychiatric residents.
Absolutely. I think psychiatry is one piece of this. I think similar questions exist for interactions between all hospital workers and ICE officers.
Great. Well, Dr. Tsymbalyuk, thank you so much for joining me to talk about this challenge. I do hope that there is clarity on these important questions soon.
I appreciate you taking the time to shed light on this.
That was Dr. Solomiya Tsymbalyuk in conversation with Dr. Josh Sharfstein, who was left with some questions. So he dialed up Dr. Katherine Peeler, a medical advisor to Physicians for Human Rights and an expert in the quality of care in immigration facilities. Let's listen.
Dr. Peeler, thank you so much for joining us to talk about this question of access to mental health care in immigration detention facilities.
My pleasure. Thanks for having me.
So I guess the question is, we have a patient in the emergency department who really needs mental health care. They're being taken to an immigration facility. What are the rules that apply in that situation?
Yeah, so ICE has several standards for medical care, both physical care and mental health care. And those standards are longstanding. If someone is actively at risk of harming themselves or others, ICE is compelled to act upon that. They have medical staff within ICE detention centers. There are doctors, there are nurse practitioners, there are nurses, there are LPNs, but who is there at any given time of day differs. And so there's various chains of command. But if someone is quite sick and actively suicidal, there are protocols in place to essentially isolate that person so they're not going to harm themselves and then to seek treatment. Whether or not they stay in the ward at a detention center versus go to the emergency department is up to ICE's discretion. I will say it's not uniform. There is a study that we can provide a link to. I'm not sure how that works here, but by Annette Decker and Parveen Parmar and their group out in California, where they looked at emergency calls to 911 from various detention centers in California and compare them to ICE's own logs of what they considered emergencies within ICE. And the reason why they were able to do this actually is because California has different laws than the rest of the country, and that they do their own oversight of ICE detention centers and don't just rely on federal oversight. And so they found actually that there were quite a significantly higher number of what ICE considered emergencies documented by ICE than there were calls to 911. And many of those were related to mental health emergencies, including potential suicidality. And so as you can see, not every someone who might be suicidal necessarily gets care in a mental health center outside of an ICE detention facility.
And let me ask you this. You went through the protocols that exist. How confident are you that those protocols are being followed?
I'm not particularly confident in the sense that has been reported in the news recently. There have been a lot of deaths in ICE detention centers just in the last few months since January 25. And they're not all suicide, to be very clear. But the point being that there are people who have had serious medical issues which have resulted in mortality. And there are many articles, one of which my team wrote, one of which, again, actually, I think Parveen Parmar's group wrote again about suicidality in ICE detention, and the rates there are much higher than the general population. And so if completed suicide rates are higher in ICE detention than they are outside, then I'm not totally confident that protocols are necessarily being followed. In addition to not necessarily being followed, I think there's the protocols, and then there's also the systems in place to allow the protocols to succeed. You and I both work in medical systems. You have policies, but then you also have the environment in which the policies exist. And you both need good policies, and you need a good environment where people feel comfortable enacting policies, where there's enough staff to enact a policy, where the staff are trained to enact the policies, to recognize when the policies apply. And all of those pieces in that puzzle don't always come together correctly in ICE detention.
Those kinds of stories and the data that you're talking about gaps in care, particularly mental health care for people in ICE detention, really can create a dilemma for a physician working in an emergency department asked to clear, as they say, a patient to go back in detention, and particularly a patient who may be suicidal.
Yes, absolutely. The dispo is ultimately in their decision, and if they're not confident the disposition is a safe one, that is certainly a dilemma and a hard place to be.
Dr. Peeler, thank you so much for joining me.
My pleasure. Thanks again for inviting me.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.